Okay, if you do this route rapid results or not. Hello, Dr. Satyaprakash, Dr. Gautam, Dr. Jilin. Dr. Jilin, I'll just answer your question. First, let me know if I'm audible and I'm visible to all of you. My screen is there visible. Any problem? Hi, Dr. Ansh, Dr. Abhishek. Good afternoon. Good to go, start, guys. Shall we start? So that's a pretty much odd time. Like I've just changed a time little bit because we've been carrying out the series of this expected questions for FMG at DocTutorials at 5 p.m. So today we'll be having a session starting from the 4 p.m. Now, guys, welcome to all of you from everybody at DocTutorials. Today we have a session in ophthalmology where we will be discussing expected questions in ophthalmology. So a very warm welcome, and your exams are approaching, so few days are left for your exams. So let's make this session very useful for all of you. We'll try that we'll discuss many questions, many different topics, something which you have read, something new, and something which I expect can be there in your exams this year. So we'll be having an approach where I have kept some questions, some clinical questions, some image based questions, and then those problem based questions will be discussed in detail. And I'll also discuss with you the approach, how to solve the questions in ophthalmology. So the first question which Dr. Jilin has been asking me, is this all rapid revision enough to pass the exam? But you see, rapid revision means what? That you know something and we are revising, we are just brushing you up for the final preparation. This is the final punch for your preparation. Yes or no, Dr. Jilin? So if you haven't touched ophthalmology, or if you haven't touched any of the subject, but if you do 2 hours of revision with us, I am not committing that you will be succeeding in your exam, you will pass the exam if you have no idea about the subject. But yes, definitely if you have learned something in the classes or you have studied your notes well, then this revision is really going to be helping you. Okay, so I'm not saying this revision is enough. No revision is enough, guys. It is that just we are taking up some very important points, something which we are revising here, so that you will have good marks in your exam. You will quickly recognize the important questions, you will recognize whatever you have learned all throughout these months, whatever you have learned in your preparation time. So that is the time we are going to revise everything in a short span of time, right? So guys, shall we start? Hope everything comes from this video only, keeping our fingers crossed. Okay. Yes, Bache, the video will be available till your exam date. So DocTutorials have done a lot of good things these days, so they have promised that they'll keep the videos till your exam date. Okay, so you can revise, you can go through all the videos till what time you can revise. Your favorite subject mentors are there, so you can revise those videos again and again. Okay, two into speed you can modify, and you can quickly revise those important topics. Chalo guys, now let's not waste the time and let's quickly start with the first question. So friends, fungal ulcer and any corneal ulcer is an expected question always. For any exam, ulcer is an expected question. So I have taken fungal ulcer. So what is not a feature of fungal ulcer? पहले आप मुझे आंसर बता दीजिए. First tell me the answer. Is it a dry looking ulcer? Do we have a convex hypopyon? Do we have neovascularization here? Or we see satellite lesions? What is not a feature? So I'm sure there's a delay somewhat of around 30 seconds. So yes, quick answers. But you see, I can see many students are there, and that is my humble request that you have to answer the questions. Okay? Take it as if you're giving your exams. We'll be quickly revising so many questions. Whatever knowledge you have, utilize your knowledge and take it this question as your exam question. Okay? आप अपने उसी टाइम पीरियड में, आप उसी अपने 30 सेकेंड्स के टाइम पीरियड में यू हैव टू आंसर सच क्वेश्चंस. इफ वी हैव अ प्रॉब्लम बेस्ड क्वेश्चंस, टेक द टाइम पीरियड ऑफ like 45 to 50 seconds, रीड द क्वेश्चन वेल, सी द इमेज एंड देन आंसर. ओके बच्चे, जो लोग सैटेलाइट लीजन्स कह रहे हैं, इज सैटेलाइट लीजन्स द आंसर? आई एम आस्किंग यू, नॉट अ फीचर ऑफ फंगल अल्सर. सो कॉर्नियल vascularization, please remember. So we have read many times in fungal ulcers that fungal ulcers are dry looking ulcers, isn't it? They are dry looking ulcers. Signs are more as compared to symptoms. Patient will be having subtle symptoms but very less signs. You have a hypopyon which is fixed and an unsterile hypopyon. So convex hypopyon is there, right? Now you may have satellite lesions, though this is not the hallmark, but satellite lesions are also there. You have feathery margins in fungal ulcers, okay? So 3 F's, please remember: fungal, fixed and feathery margins, okay? These 3 F's are very, very important. Now apart from that, please remember, vascularization in a case of fungal ulcer is very, very, very less commonly seen. What else is not seen is perforation. So perforation in a case of corneal ulcer, like a fungal corneal ulcer, is a rare event. Okay? Perforation is also not seen in cases of fungal ulcer. Okay? So please remember all those things. Convex, nahin, Dr. Vendan, convex does not mean non-sterile. Convex means that we have given it a shape like this. It is a convex hypopyon because it is a thick curdy hypopyon and it is a fixed hypopyon. It does not change its size and shape when you have the change in position. I have just given a different name. Okay? Somewhere in some books, convex hypopyon is also given a term. Okay? I am sure voice is little low. Dr. Vicky, is the problem at your end or मेरी voice सबको कम आ रही है? Okay, Dr. Vendan, have I answered your question? Convex does not mean non-sterile. Convex means the shape of the hypopyon, and fixed and unsterile is something different. Okay? Okay? So please remember 2 things I have told you. Perforation is also very rare in fungal ulcers. Vascularization is also very, very rare in case of fungal ulcers. So what is the treatment of choice? So the treatment of choice for fungal corneal ulcers is 5% natamycin. This is your treatment of choice. Okay? Chalo. So let us see again a case of fungal corneal ulcers. We have feathery margins. We don't have a sharp punch delineated ulcer. We can have small satellite lesions. That means small multiple ulcers in the vicinity of the main ulcer. Then we have a ring shape ulcer. Ring ulcer is also called as the immunological ring of Weasley. Please remember, satellite ulcers, satellite lesions and ring lesions are not pathognomic for fungal ulcers. You can have ring lesions in other ulcers as well. Okay? Please yaad rakhna. Feathery margins are specifically for fungal corneal ulcers, but satellite lesions and ring infiltrates are not specific for fungal ulcers. You can have these 2 things in many other ulcers as well. Okay? Please remember. Now, chalo, again a very, very important topic. Please read the question well. Refractive status is unaffected by. Refractive status of the eye. You know what is the refractive status of the eye? We are emetrope, hypermetropia or myopia. So it is not affected by axial length, thickness of the lens, anterior chamber depth or vitrectomy. Yes, Dr. Mir, you are absolutely right. Contact lens ulcers can also show ring ulcers. बिल्कुल ठीक. तभी मैंने कहा that ring ulcers are not specific for fungal ulcers. So D is an incorrect answer, बच्चे. D is an incorrect answer. So, refractive status is unaffected by the anterior chamber depth. This is the important answer, okay? Now, let us go with the question because this is an important topic. Chalo, baat karte hain. So, please see, this is the normal ray diagram where the parallel rays of light are coming to a focus point at the retina. This focal point of the retina is called as fovea. I hope you remember, this is the normal diagram of an emetropic eye, okay? What is emetropia? Emetropia is a refractive status of the eye where parallel rays of light are focusing and one point of retina, that is called as fovea. ठीक है? अगर अब मैं आपसे ये वाला सवाल पूछूं तो इसमें क्या आंसर होएगा? Which refractive surface has the maximum contribution to the refractive power of the eye? So if you remember, the refractive power of the eye as a whole is around plus 60 diopters, and from that plus 60, almost 43 diopter is contributed by cornea. I hope you remember. So what will be the answer of this question? Maximum refraction is contributed by cornea. I hope you remember this thing. Now the rest of the contribution is from the lens. Okay? So please remember, refractive power of the eye, refractive status of the eye is definitely dependent upon the lens thickness. Definitely it is dependent. Now what about axial length? So again, I hope you remember, friends, if you have 1 millimeter increase in the axial length, this induces a myopia of around 3 diopters. Do you remember, friends? If there's an increase in the axial length of the eye, the introduction of the myopia will be around 3 diopters. You remember the concept? Similarly, if you have a decrease in the axial length of the eye will become hypermetropic by 3 diopters. So there is definitely a role of the axial length. Okay, if your lens is more thick, the refractive power will change. If the lens is less thick, the refractive power will change. Now what about vitrectomy? So guys, please remember, vitreous and aqueous humor, they also contribute in the refractive power, though a little, but they have a contribution. Okay, you remember the refractive index of the vitreous humor? Do you remember? Can anybody tell me what is the refractive index? What is the refractive index of the vitreous humor? So it is around 1.34. So it definitely contributes to some extent of the refractive power of the eye. So guys, in vitrectomy eyes, like where we have removed the vitreous humor, there is certainly a change in the refractive status. Okay, please remember, this can be an expected question. So once you do a vitreous surgery, once you have done a vitrectomy, there can be introduction of generally a myopia. Okay, but yes, you can have a hypermetropia as well. So there will be a difference in the refractive status of the eye. Okay, Dr. Mir bilkul absolutely right. Once you have a buophthalmos is a long eye, big eye, so the patient will have a myopia. Simple, very nice, good. Now somebody is saying lens contribution is 19 diopters. Guys, I am not saying it is not, it is incorrect. Lens contributes from around 15 to even 19 diopters. Okay, this is like 15 to 19 diopters. I'm not saying it is only 15 or it is only 19, but it is variable. Okay, Dr. Satya Prakash. So cornea is 43 and lens is 19. So again, just quickly revising the refractive indices. So guys, please remember, air has a refractive index of 1. So as compared to air, cornea is 1.38, aqueous humor and vitreous humor 1.3334, and lens has a refractive index of around 1.39, which becomes 1.42 in the center. Okay, it's a very basic thing which one has to know. Chalo, now let us try to answer this question. So phacomorphic glaucoma is seen in which type of cataracts? First I want answers from you. So phacomorphic glaucoma is seen in where? Now the correct answer to this question is mature intumescent cataract. Okay, now let us quickly revise what is the meaning of the term phacomorphic glaucoma and what is the meaning of the term intumescent. Now guys, you remember the stages from which a senile cataract goes through. So it starts with like lamellar separation, then you see immature senile cataract, then we have a mature senile cataract, and then we have a hypermature senile cataract. तो जो आप लोग बता रहे हो hypermature Morganian cataract, बच्चे, what is the complication here? You have a complication of a phacolytic glaucoma. What I am asking you is a phacomorphic glaucoma. Chalo, let us first discuss this phacolytic glaucoma because most of you are answering a phacolytic glaucoma here as the answer. Okay, पहले हम यही discuss कर लेते हैं. So guys, what happens when you have a HMSC Morganian type? Let us see what happens. So friends, when we have a HMSC Morganian type of cataract, this is the picture what we see. This picture is called as a bag of milk appearance. ठीक है, bag of milk. तो क्या होता है bag of milk में? Because your cortical matter has all liquefied. This is your liquefied cortex. So your central nucleus gets sunken down. Nucleus नीचे बैठ जाता है. ठीक है? Now when this happens, you also develop small ruptures in the anterior capsule. Now through these ruptures in the anterior capsule, your lens matter, lens proteins, okay, proteins, not matter, lens proteins goes out. They go out and they get accumulate in the trabecular meshwork, in the angle of the anterior chamber. When they accumulate in the angle of anterior chamber in the trabecular meshwork, they block the aqueous drainage. Resulting this is your IOP becomes high. When your IOP becomes high, it leads to a glaucoma. And what is the name of the glaucoma? Phacolytic glaucoma. So please remember, phacolytic glaucoma is seen in hypermature more ganglion cataracts. ठीक है, आप इसका आंसर बता रहे हो, but I am asking you mature intumescent cataract. So many a times, I'm not saying all the cataracts, but many a times when the cataract is in the stage of mature phase, so there is sudden imbibition of lot of fluid within the lens. Okay, let us see a picture. So what happens? Suppose this is your normal lens. Okay, this is your normal lens which is now mature. So all the lens fibers are now opaque. But suddenly at one point of time, in few patients, there is a rapid influx of fluid within the lens. Because of that, your lens becomes stout. The lens becomes as if it is 9 months pregnant. So what will happen? Because the lens has changed its morphology, lens has become like this. बहुत मोटा फूल गया एकदम, ठीक है. जब ये ऐसे फूल जाता है तो what will happen? It is going to block the pupillary area. Okay, it is going to block the pupillary area. So it is going to cause a pupillary block glaucoma. And this pupillary block glaucoma, see the picture, what is happening? This is becoming intumescent, sudden influx of fluid within the lens. Because of that, it is going to block the pupil. So it will push, it is going to cause a secondary angle closure glaucoma. This glaucoma is a secondary angle closure glaucoma. Okay, so this is because of change in the configuration of the lens. That is why we called it morphic glaucoma. Okay, will you be able to remember, guys? ओके, हाँ जी, फेकोलाइटिक अर्जुन डिफरेंट है और ये वाला बिल्कुल डिफरेंट है. सो दिस इज जनरली सीन इन केसेस ऑफ इंट्यूमेसेंट कैटरेक्ट. ओके, सो दिस क्वेश्चन कैन बी आस्क्ड टू यू एंड दिस इज एन इंपॉर्टेंट पिक्चर. दिस इज कॉल्ड एज बैग ऑफ मिल्क अपीयरेंस. आई होप यू रिमेंबर दिस. ठीक है, चलो. Now something from cornea again. Which of the following is not a characteristic of vortex keratopathy? अब ये vortex keratopathy क्या थी? Guys, if you remember, we have read many times in class and lectures also have told you that this is a broomstick kind of accumulation of drugs on the cornea. Okay, so there are certain drugs which leads to cornea verticillata. Okay, this can be an important topic, guys. It can be seen in chronic use of medications like amiodarone. Many a times you have got a question, vortex keratopathy is seen in which drugs? So when you take certain drugs, especially amiodarone, for a chronic use, you can have deposition within the cornea. So this is a correct statement, Dr. Murli. Okay, this is a correct statement. Now chloroquine also can cause this. Chloroquine is another drug which leads to this type of vortex keratopathy. This is a correct statement that when you stop the usage of the drug, it can gradually resolve. But this is important. Does it cause a decrease in vision? Very, very less common. Okay, this is a good point about vortex keratopathy, that even if you have such kind of accumulation within the cornea, but the vision almost always remains normal. That is a good point. Okay, now I'll quickly revise vortex keratopathy with you because this is an important question. Please remember, first of all, the picture. Accumulation of drugs in this fashion, this is called as vortex keratopathy. It is same as cornea verticillata. ठीक है, both the things are same. Okay, first of all, this is a picture question. Okay, so vortex keratopathy is same as cornea verticillata. Many a times you have got question on amiodarone. So please remember, what are the rest of the drugs? We can remember this by a simple mnemonic: Cadbury keeps you fit. Though you will say, ma'am, Cadbury doesn't keep you fit, it adds a lot of calories on you. But yes, mentally you can have Cadburies when you are depressed. ठीक है, no one is giving right answers. इस देश को क्या हुआ? कोई बात नहीं, Dr. Prashant, I am there to give you right answers. It's okay. It's okay. We are learning today. So, Cadbury keeps you fit is the mnemonic. What is C here? C is chloroquine, chlorpromazine. A is amiodarone, D is diclofenac. What about fit? Fabry's disease, indomethacin and tamoxifen. So tamoxifen is another important question which you can have in your exam. ठीक है, so tamoxifen से भी cornea में accumulation हो सकता है. This can be a problem based question also, guys. Please remember, vision remains normal and after you stop the usage the drug, the changes can be reversed back. Okay, important expected question. चलो, ये हमने बहुत बार पढ़ा है. हाँ जी, so can you answer what is not a cause of blue sclera? Down syndrome, a premature infant, Ehlers-Danlos syndrome, or pseudoxanthoma elasticum. So first of all guys, what is blue sclera? Is that a blue sclera where I have put some color in the sclera or in the eye, or there is some pathology where there is a discoloration of sclera? Yes. Anyone, any answer? So guys, please look at this picture because this can be a picture question also. So here, first thing which I would like to tell you is this: nothing has happened to the sclera. Sclera is not of blue color. Actually, there is a thinning of the sclera. So once your sclera becomes thin, the underlying choroid will shine through it, and this is giving a blue color to the sclera. Okay. Now let's go back to the question. Please remember, pseudoxanthoma elasticum is a very important cause rather of blue sclera. मैंने पूछा है what is not a cause. So what is not a cause? To remember this, you can easily learn a mnemonic. What is the mnemonic? Boss have multipolar disorder. Okay, though nobody likes the boss, है ना? Boss को कौन पसंद करता है? So here you can learn the mnemonic very easily. B is buphthalmos. O is osteogenesis imperfecta. Dr. Satyaprakash absolutely right. Osteogenesis imperfecta is one of the causes of blue sclera. ठीक है? Scleritis is one. Staphyloma is one. So we are done with boss. What about have? Hypophosphatasia, alkapentouria, Van der Hoef syndrome, Ehlers-Danlos syndrome. M is myopia, Marfan's. Again, we have two M's here, myopia and Marfan's. Please remember, very important question. Again, we have two P's, Paget's and pseudoxanthoma elasticum, and the last one, D, is Diamond-Blackfan syndrome. Okay, because you have a premature infant, the sclera is supposed to be thin. When you have thin sclera, you can definitely have a blue sclera. So what is odd man out? We do not have a blue sclera in cases of Down syndrome. This is your answer. Okay friends, we don't have blue sclera in cases of Down syndrome. Please remember an expected question. और बहुत कॉमनली आपसे पूछा जा चुका है दैट ब्लू स्क्लेरा इज सीन विद. So Paget's disease was one time a question. Pseudoxanthoma elasticum was also asked. Osteogenesis imperfecta, you all know. So basically these are the disorders where there is an inherent problem of the collagen synthesis. That is why your sclera is thinned out. ठीक है? Is that okay to all of you? Now, something from a very important topic in ophthalmology. Since last many years you're getting a question on keratoconus. So I would say keratoconus is, guys, a very important topic. I have given you a problem based question. Let's read out the question. So we have a young female patient complaining of repeated change in glass number. She was diagnosed to have an early keratoconus on topography. So please remember, what is topography? Pentagram. ठीक है? So topography is your pentacam, which is the diagnostic modality of the choice. ठीक है? This is your diagnosis of choice. So you have diagnosed that this female is having a keratoconus. Why keratoconus? Because she has a problem of repeated change in glass number. That is the problem, that is the complaint by which your patient comes to you. ठीक है? Now, obviously, she is not having a good vision through glasses and she is not even comfortable with them. ठीक है? So which type of contact lens is best suited for her? अच्छा, अब देखेंगे क्या हम इसको soft contact lens देंगे? बच्चे बिल्कुल भी नहीं, absolutely not. Please remember, in keratoconus or in any other corneal ectatic disorder, we never give soft contact lens. यहाँ पे क्वेश्चन का क्या मतलब है? यहाँ पे क्वेश्चन का मतलब ये है कि पेशेंट को ग्लासेस से कंफर्ट भी नहीं मिल रहा है एंड पेशेंट इज नॉट गेटिंग अ गुड विजन विद ग्लासेस. So what here we have to do? We have to give the patient rigid gas permeable lenses. And what is the name of rigid gas permeable lenses? Rose K lens. ठीक है फ्रेंड्स, दिस इज एन इम्पॉर्टेंट टॉपिक. रिजिड गैस परमिएबल लेंस होते हैं जिनका हमने क्या नाम रखा है? रोज के लेंस. So you can have questions in a different way. They can ask you, rose K lens can be used in which disorder? So the answer is keratoconus. Okay? If rose K lens is not in the option, rigid gas permeable lenses would be in the option, or a semi hard contact lens will be in the option. Now what is the role of this rose K lens? हाँ जी, डॉक्टर गामा नाइफ, लिसन टू मी. बच्चे ये जो सॉफ्ट कॉन्टैक्ट लेंसेज हैं, सॉफ्ट कॉन्टैक्ट लेंसेज आर जनरली मेड अप ऑफ हेमा. व्हाट इज हेमा? हाइड्रोक्सी इथाइल मेथेक्राइलेट. सो दीज आर your cosmetic lenses. Suppose I have a myopia and I don't want to wear glasses, so I can use soft contact lenses for cosmetic purposes, right? Now, hard contact lenses and rose K, rigid gas permeable lenses, are meant for mainly keratoconus type of disorders where, see, cornea is like this, okay? Your cornea is becoming thin in the center and it is ectasia also. Now, if you place a rigid contact lens over it like this, or a rose K lens like this, it is said that these lenses will slightly alter the shape and curvature of the cornea back to normal, and that's why what we want. If you use these lenses for a prolonged period of time, they will alter back the curvature of the cornea. यही तो हमको चाहिए, है ना? So yes, we do give contact lenses, but these contact lenses are rigid gas permeable lenses or rose K lenses, ठीक है? Cylindrical specs और सी डॉक्टर अभिषेक, आपका क्वेश्चन है कि अगर ऑप्शन में सिलेंड्रिकल स्पेक्ट्स हो, बेटा अगर सिलेंड्रिकल स्पेक्ट से पेशेंट का विजन क्लियर हो रहा है एंड यू हैव सीन दैट केराटोकोनस हैज़ नाउ स्टॉप्ड, इट्स नॉट इंक्रीजिंग फर्दर, you can give the cylindrical specs also. But if you see that keratoconus is progressing, you want to halt it, you want to let the cornea go back to its normal curvature, then you must give rose K lenses. Okay, ठीक है? बच्चे क्यों डॉक्टर केसवानी, we do give lenses बेटा. Okay, Dr. Trilok, we do give such kind of lenses. Have you understood the topic here? See, glasses is a very temporary option. Every 4-5 months when the patient comes to you with a change in number, you can give the glasses. But what about the corneal curvature? Is it going back? No. What about the progression? Is it going back? No. So what is the treatment of choice for stopping the progression? Anyone? My question. What is the treatment of choice for stopping the progression? How you can halt the progression? Anyone? Anyone? The answer will be C3R. C3R is the treatment of choice for halting the progression. You can stop the progression. ठीक है? But C3R will not take the curvature back. How can you take the curvature back? With the help of rigid gas permeable lenses or even the Intacs. ठीक है? चलो, good. केराटोप्लास्टी कब करते हैं बच्चे? नहीं बच्चे, केराटोप्लास्टी हम हॉल्ट प्रोग्रेशन के लिए थोड़े ना करते हैं. व्हेन आर वी गोइंग टू डू पीके, पेनिट्रेटिंग केराटोप्लास्टी? इन द वर्स्ट सिनेरियो व्हेन यू हैव हैड अ परफोरेशन एंड व्हेन यू हैव डेवलप्ड अ कॉर्नियल ओपेसिटी. ओके, याद रहेगा डॉक्टर आयुष एंड डॉक्टर गामा. So the favorite question of examiners, what about Munson sign? Munson sign, please remember, it's notching of the lower lid when you look down because of the bulky cornea. But please remember, Munson sign is not a very early sign. It comes late. ठीक है? It comes late. Now I'm quickly enumerating what are the different signs in keratoconus so that we can quickly revise the topic here. So it is seen in young females mainly at the age of 18 or 20 years. There is a astigmatism or a myopic astigmatism, but never a hypermetropia. You can have an oil droplet reflex. You can have a residual reflex. You can have a scissoring on retinoscopy, Fleischer's ring, walked stripe, prominent corneal nerves, Munson sign, late sign, and you can have acute hydrops as well. Okay? The treatment is early cylindrical glasses, rigid gas permeable rose lenses, then you can do C3R for halting the progression. Penetrating keratoplasty was the worst cases. Okay, so this is all about your keratoconus. Please remember, pentacam is the diagnostic modality of choice. Okay, what do you see in pentacam? Guys, if this is the picture which comes in your exam, please see green means okay. Green means cornea is okay, no problem in the cornea. But if you have red areas in the cornea, suppose if this shows you red, that means there's a thinning. That means there's a problem. So that's all you have to remember. Thinning is bad. Okay? Chalo, something simple. So you've done in your PSM also. Mass prophylaxis in the population in trachoma is indicated when children between 1 to 9 years of age shows prevalence of what? So can anybody answer? हाँ जी, ये हमने बहुत बार पढ़ा है. Please remember, cases of active trachoma is mainly seen in children. Active trachoma. So we say that if the prevalence is more than 10% in this age group, not in total population, okay, not in total population, we see if the active cases of trachoma prevalence is more than 10% in this age group, not in total population, then you must give mass chemoprophylaxis. तो अब मैं आपसे पूछ रही हूँ मास कीमोप्रोफिलेक्सिस में कौन सा ड्रग दिया जाता है? Which drug should be given for mass chemoprophylaxis? सब गलत पलत बता रहे हो. Dr. Shabnam, now are you able to recognize, you able to recall? See, there's a very small difference in between these two words, in the total population or in the children between 1 to 9. So please remember, yes, it is in the age group 1 to 9. It's not in the total population. Okay? So generally for the mass chemoprophylaxis, we give tetracycline generally. Okay? Tetracycline is a cheaper drug. We give ointment tetracycline. We also call this a blanket therapy, blanket chemoprophylaxis, blanket treatment. So we say intermittent prophylaxis should be given. We can give azithromycin as well, but generally it is tetracycline. Okay? Yes, Dr. Vicky, Dr. Rami is very good. It is tetracycline we generally give. Okay? Okay? Chalo. So very small things we should know. WHO defines trachoma elimination as when trachoma follicles 5% in this age group and intense trachoma stage is 1 upon 1000. ठीक है, these definitions you must have read in your PSM as well. Okay? So छोटी छोटी चीज़ें बच्चे ये याद रखनी ही रखनी है. अब another important topic, something related to endophthalmitis. So we have read this endophthalmitis in detail. Now I am asking you, for the treatment of endophthalmitis, what should not be given initially? So should we give antibiotics? Yes, of course. Antibiotics should be given. Topical antibiotics have a role. What about intravitreal injections? Definitely friend, intravitreal injections of antibiotics are the treatment of choice. Yes or no? They are generally the treatment of choice. When the patient comes, you diagnose the patient, then definitely you must give intravitreal antibiotic injections. What about cycloplegics? Cycloplegics to देंगे ही ना. Why? Because they reduce the pain. Isn't it? So these are very important drugs because they are the ones which will reduce the pain. Now what about steroids? क्या हम steroids देते हैं endophthalmitis में? Guys, we can give clinically to decrease the inflammation, but not in the initial phase. Not in the initial phase, okay? So later on you can start with steroids clinically, practically, but not in the initial phase. It's a, you can rule out this as well. या आप इजीली रूल आउट कर सकते हैं, ठीक है? सो नाउ आई एम टेलिंग यू समथिंग अबाउट endophthalmitis. We will be discussing quickly in 1 minute what is post-operative endophthalmitis. So look at me. Now friends, endophthalmitis means a very severe inflammation of the inner contents of the eyeball, which includes the vitreous inflammation as well. Most commonly it is caused after cataract surgery, but even after any intraocular surgery you can have that. The most common organism for early endophthalmitis is Streptococcus what? Cons. That means your coagulase negative staph. For late endophthalmitis, you can have a fungus or a Propionibacterium acne. The patient comes with PVR, pain, decrease in vision, red eye after the cataract surgery. What I see is anterior segment inflammation with a vitreous inflammation, and very important is this hypopyon. Now when I see this patient, diagnose it as endophthalmitis, my first treatment is intravitreal injection of antibiotics. Okay? Now if the patient doesn't improve, I can also do a pars plana vitrectomy on the second day. Okay? Now please remember, there is no role of intravenous antibiotics or oral systemic antibiotics. Please remember, this is also a very, very important concept. Okay? For decreasing the pain, we should give cycloplegic agents. We can give steroids, but in late phase, not in early. Okay, so this is about endophthalmitis, a very important picture question as well. Now, मुझे ऐसा लगता है कि retinitis pigmentosa पे इस बार question आने वाला है in one or the other form. So let us discuss quickly retinitis pigmentosa. Which syndrome is not associated with RP? A beta lipoproteinemia, NARP is narcolepsy, ataxia, retinitis pigmentosa, Refsum's disease or keratoconus. So what is not associated with RP? Very simple. Easy answer is keratoconus. So keratoconus is no way associated with retinitis pigmentosa. Now guys, what is डॉक्टर नवीन सी बचे स्टेरॉइड्स का क्या काम होता है? इन्फ्लेमेशन कम करना है ना. एंड एंडोफ्थल्माइटिस इज व्हाट? इट इज़ अ वेरी सिवियर इन्फ्लेमेशन, है ना. So we practically give steroids, but in a later phase, after we have this hypopyon which is gone, patient is improving, the infectious part is controlled. ठीक है? But please remember, it's not given in the initial phase, and that's what I had in the question. Okay. So keratoconus is the correct answer. Now I'll quickly discuss retinitis pigmentosa with you, friends. Retinitis pigmentosa is what? So it is an idiopathic degeneration of photoreceptors, rods and cones. Rods are more commonly degenerated. Most cases are sporadic. Most cases are not familial. Most are sporadic. But you can have autosomal recessive, autosomal dominant and X-linked cases as well. Now, when you have RP, the patient generally is a young boy. 10-year-old, 15-year-old who comes to you with complaints of night blindness because rods are gone. So what I see is triad. What is that classical triad? BAP. Bony spicules, attenuated vessels and pale disc. So that is a picture question, friends. If you have such kind of bony spicules in the retina, कुछ ऐसे आपको pigmentary areas मिले, that means you have retinitis pigmentosa with a history of night blindness. Vessels will become very thinned out and you may have a pale disc as well. Now, there are many syndromes which are associated with retinitis pigmentosa. We have a mnemonic curl black fan. सारा याद करने का ज़रूरत नहीं है, but please remember Usher's disease, Refsum syndrome is important. NARP I have already given an A beta lipoproteinemia where you can have acanthocytes. ठीक है. अशर सिंड्रोम में बच्चे को सेंसरी न्यूरल डेफनेस भी होती है. लॉरेंस मून बीडल सिंड्रोम में बच्चा इज शॉर्ट, स्टबी. ठीक है. तो मेंटल रिटार्डेशन भी होता है. थोड़ा थोड़ा सब कुछ पता हो तो यू विल बी एबल टू सॉल्व योर क्वेश्चन. नाउ व्हाट इज द ट्रीटमेंट? As Dr. Ramesh has explained very nicely, ERG is done. ERG is the investigation of choice. Even in initial stage of RP, you will have a decrease in the B wave amplitude. Important, very important. तो कोई ट्रीटमेंट बताएगा? How will you treat? Or in other words, can you treat? We can't treat. So we can give just a vitamin A supplementation to prolong the onset of blindness. But treatment is not there. कौन सा जीन है आजकल जो दिया जा रहा है? सो वॉटी जीन. Okay, वॉटी जीन trials are being done throughout the world where you can give वॉटी जीन in some cases of retinitis pigmentosa. ठीक है. This can be a new question. वॉटी जीन कौन सी डिसऑर्डर में देते हैं? रेटिनाइटिस पिगमेंटोसा में दे सकते हैं. ओके. डॉक्टर शिवा शंकर, ERG इज इलेक्ट्रोरेटिनोग्राम. ऐसे था ना? A negative wave, B wave and then C wave. A wave is a negative wave, B and C. तो initial cases में क्या दिखेगा? B wave का amplitude कम हो जाएगा. The amplitude of B wave will be decreased. Later on you can also have a flat ERG. No wave. Dr. Naveen, you can have autosomal recessive, you can have autosomal dominant, you can also have X-link. All three can be seen. But most common cases are sporadic. If you talk about inheritance, this is the most common inherited. Okay, autosomal recessive is less common and this is least common. Dr. Naveen, समझ में आ गया? You can have all. Okay, better show me a thumbs up if you have understood. Now another important topic which I want you to know is about trauma, and here I have taken a case of sympathetic ophthalmitis. So I am asking you not true regarding sympathetic ophthalmia. So is it more common in suppurative eye? Is it more common in injuries of ciliary region? High doses of steroid can be given as a treatment. Blurring of near vision and photophobia are early signs. Yes. So definitely sympathetic ophthalmia is because of a penetrating injury. I hope you remember it is because of a penetrating injury to the ciliary region of the eye. This is a correct statement. When you have ciliary body is your danger area of the eye. If you have a penetrating trauma, you can have sympathetic ophthalmia. High doses of steroid can be given because it is a kind of panuveitis. You have a very severe inflammation of whole of the uveal tract. So high dose steroid or immunomodulatory drugs can be given as a treatment as well. Now, if you have a penetrating injury in one eye, your other eye can develop a sympathetic ophthalmia, which is a non-traumatic eye. So it is not common in suppurative eye, rather it occurs in non-suppurative eye. If you have a suppuration, if you have pus formation, sympathetic ophthalmia will not occur. So please remember, this is your answer, okay? Now, if the patient is developing a sympathetic ophthalmia, then blurring of near vision and photophobia are definitely not signs, but they are early symptoms. The patient will come to you with problem of photophobia and decrease in near vision. Okay, please remember, these are the common and early symptoms. Okay, now I have given you the treatment, that high dose steroids will be given for the treatment. But what about prophylaxis? So can anybody tell me what is the best prophylaxis to prevent sympathetic ophthalmia? Can anybody tell me what is the best prophylaxis? The best prophylaxis is enucleation of the traumatic eye. Yes or no? So best prophylaxis is enucleation of the traumatic eye. This is your best prophylaxis. If you have a doubt, no fight. Wonderful. So no fight is the best prophylaxis. Nothing can be better than that. Nothing can be better than that. But yes, if at all you had a fight, and if at all there is a penetrating injury to the ciliary region, then enucleation of the traumatic eye. Nahi evisceration nahi karte, Dr. Ramesh. Please remember the question. Evisceration is rather absolutely a contraindication. It is contraindicated in these cases. Okay? Any other area where evisceration is contraindicated, can you tell me? Remove the damaged eyeball, yes. Hanji. Any other condition where evisceration is contraindicated? Dr. Naveen galat bata rahe bache. Evisceration is a contraindication. We do not do. So another contraindication of evisceration is tumors of eye. Okay? Tumors of eye. Like retinoblastoma. We never do evisceration. Okay? Good. Chalo. Something which you already know. Try to answer. Not an indication to do a photocoagulation. If you have new vessels in the iris, guys, if this is your iris, suppose that is your iris, and you have new vessels at the level of iris, will you do a photocoagulation? Yes, absolutely. What about macular edema and neovascularization of disc? I hope you remember that neovascularization of disc means proliferative diabetic retinopathy. And what is the treatment of choice for PDR? It is PRP. Pan-retinal photocoagulation is the treatment of choice for PDR. Definitely, you will do a photocoagulation. What about macular edema? So guys, if you have edema on the macula, you can also do a photocoagulation, but that will be a grid laser, which will have less power. Because we have been reading that in pan-retinal photocoagulation, macula is not lasered. But if you have a macular edema, you can do a photocoagulation. Very, very good. The correct answer here is macular hole. If you have a hole in the macula, there is no point of doing a photocoagulation. Okay? Very good. Those who have marked D, D is the correct answer. Okay? Now somebody is asking me about the difference between evisceration and enucleation. But I don't have a photo today, but yes, I'll try to explain. In enucleation, we take out whole of the globe. We take out the whole of the eyeball with a part of the optic nerve. We take out the sclera. We take out the muscles. And we just detach all the communication with the body. Okay? Now, what about evisceration? So in evisceration, if this is your eyeball and this is your limbus cornea. So first of all, you remove the cornea. You remove the cornea and then inner contents of the eyeball are scooped out. Okay, inner contents of the eyeball are scooped out. Sclera remains within the body. Sclera, optic nerve, muscles remains within the body. Okay? Chalo, अब बताओ ये important question. So what is the following is not a criteria for ROP? Retinopathy of prematurity के लिए क्या criteria, क्या risk factors नहीं है? So macular hole. See, Dr. Naveen, macular hole is a full thickness hole in the fovea or the macula. Full thickness. That means all the layers of the retina, they have become defected. Hole ban gaya. So the most common cause of this macular hole, so I'm going back to macular hole guys. The most common cause of macular hole is idiopathic. We don't know. Idiopathic होन हो जाता है, ऐसा देखा जाता है ओल्ड एज में, मोस्टली इन सेनिलिटी. इट्स नॉट अ वेरी कॉमन थिंग टू हैपन, बट whenever it happens, it is there generally in old age. Sometimes trauma can also lead to macular hole. Laser photocoagulation, whatever photocoagulation we are doing, this is actually a risk factor for having a macular hole. Okay, apart from that, you can have a cystoid macular edema leading to a thinning of the retina, later on leading to finally a hole. Okay, so mostly this is the cause. And you know, if you happen to see a solar eclipse, then also hole can occur in the macula. ठीक है बच्चे, चलो अब वापस से आ जाओ रेटिनोपैथी ऑफ प्रीमेच्योरिटी पर, विच इज नॉट ए क्राइटेरिया. सो गाइज, what is the guidelines here? When should we screen? What is the risk factor? So risk factor is when the baby is less than 34 week of gestation. So definitely less than 22 is a criteria. What about the weight? Weight should be less than 2 kg. So this is correct one. What about sepsis? Yes friends, sepsis is also there. If your baby is premature, is preterm baby, and he develops a sepsis and he has to stay in neonatal ICU, or the patient has any other perinatal event, the baby didn't cry well, the baby has a hypoxic spell or any other infection, so this becomes a risk factor for development of retinopathy of prematurity. ठीक है. What about Down syndrome? Down syndrome is not a criteria for ROP. ठीक है, Down syndrome की अलग कहानी है, this is entirely different. So please remember, the revised criteria is very simply remember 2, 3, 4. What is 2, 3, 4? Birth weight less than 2 kgs, gestational age less than 34. ठीक है, you can remember this very very simply. ठीक है, so this can be another important expected question. चलो guys, I'm quickly telling you about the 5 stages of ROP because this can be again a question. Once you have a retinopathy of prematurity, in stage number 1 you get a demarcation line, that is the line between the normal retina and the avascular retina. ठीक है. In stage 2 the line becomes thick, it gains height and width, so it becomes a ridge, you call it the ridge. ठीक है. In stage number 3 you have extra retinal fibrovascular proliferative bands. ठीक है, so you develop new vessels. In stage number 4A you get a partial tractional type of retinal detachment. In stage number 4B you get a total tractional retinal detachment. I am sure I need not to explain you why you develop a tractional retinal detachment here. ठीक है, it's a vascular disorder of retina, so you will develop a tractional type of retinal detachment. ठीक है, so they can ask you very simple question, tractional retinal detachment develops in what stage of ROP? So you have to stay stage number 4 if you have a tractional type of retinal detachment. ठीक है, ये important expected question है. चलो, now something very very easy, common sense. Which of the following is not a manifestation of blunt trauma of the eye? Anyone? ये बहुत simple है, बताइए. Doctors Club, just think about it बच्चे. Blunt trauma, will you have a perforation of cornea in blunt traumas? क्या कॉर्निया फट जाएगा blunt trauma से? Very rarely, है ना. So rosette cataract is a definitely a manifestation of blunt trauma. Tear in the sphincter pupillae muscle, yes, blunt trauma में हो सकता है. Retinal dialysis is what? Separation of the retina from its root. You can have this in blunt traumas as well. But what about perforation of cornea? क्या cornea फट सकता है blunt trauma से? No. So the correct answer here is corneal perforation. I am asking you which is not a manifestation. ठीक है, so perforating injury थोड़ी हो जाएगी blunt trauma से. Now am I right? Are you able to understand friends why the answer is D? अच्छा मुझे ये बताओ, iridodialysis सुना है? You remember iridodialysis? What is iridodialysis? When you have a separation of iris from its root. You remember? You get a D-shaped pupil. This is your D-shaped pupil. I hope you remember. This is the picture of iridodialysis. Now friends, iridodialysis occurs when? When you have a blunt trauma. Yes or no? Similarly, you can have retinal dialysis when you have blunt trauma. मतलब क्या हुआ डायलिसिस का? मतलब कि वहाँ से फट रहा, वहाँ से वो निकल रहा है जहाँ से उसका रूट है. So iridodialysis means separation of iris from its root. Retinal dialysis means separation of retina from its root. अब ठीक है everyone, ये easy था. This was easy. Perforation of the cornea will not occur in blunt trauma. Yes or no? तो ऐसे आपने क्यों लिखा? आई थिंक आपने इसलिए लिखा रेटिनल डायलिसिस बिकॉज यू हैव नॉट हर्ड ऑफ इट. Is it, guys, answer me. Did you write C as the answer because you haven't heard of the term? So is this the way to solve a question? Tell me. If you haven't heard of a term, will you think that this is the correct answer? I haven't heard of it, so this should not be a manifestation. बच्चे ऐसा नहीं है. This is not the way to solve the question, है ना? Just use sometimes your common sense as well. Sometimes, you know, ब्लंट ट्रॉमा में परफोरेशन कैसे हो जाएगा? ठीक है. I know most of the students mark such kind of answers because they think that this is a new term, so this should not be there. I haven't heard of it, so this should be the answer. No, but sometimes you have to see other options as well. Sometimes try to use a bit of common sense, and many a times I'm sure you will be, you know, you'll happy to get the answer as a correct one. ठीक है. ऐसे तो बहुत सारे टर्म्स आएंगे बच्चे जो हमने सुने ही नहीं होंगे ना. दिल बी सो मेनी न्यू टर्म्स इन द क्वेश्चन, न्यू टर्म्स. यू आई एम श्योर मोस्ट ऑफ अस, हमारे साथ भी ऐसा होता है. इवन आई गेट टू नो समथिंग वेरी वेरी न्यू इन द एग्जाम. अच्छा दिस ऐसे भी पैथोलॉजी है, ऐसे भी क्वेश्चंस हैं. सो इट्स द वे दैट यू शुड नॉट आंसर सच थिंग्स. चलो ये बताओ अब. दिस इज सिंपल. दिस इज समथिंग अबाउट रेटिनोस्कोपी. अ पेशेंट हैज रेटिनोस्कोपी ऑफ -2 diopters fair at 1 meter. The reflex during retinoscopy will move how? So this is about retinoscopy, friends. When I am using my retinoscope and I am moving, look at me, I am moving my retinoscope in this direction, and the reflection in the patient's cornea is moving in this direction, like this, opposite. So what is the inference? The inference is the patient has a myopia of more than -1. More than -1. ठीक है. याद आ रहा है? Now what about move in same direction? If the reflection is moving in the same direction, look at me. If the direction is in the same direction, it means what? It means either the patient has a emetropia or a very small myopia of less than -1 or a hypermetropia. ठीक है. These will be the inference. What about scissoring reflex? Scissoring reflex means the patient has a keratoconus. याद है? अभी पढ़ा keratoconus. Okay. So this is the correct one. Move away. Move away means moving in the opposite direction. So -2 means more than -1. This is a myopia more than -1. So the reflex will be moving in the opposite direction. ये सबको क्लियर हुआ है कि नहीं? प्लीज लेट मी नो. Hypermetropia or myopia less than 1 means move in the same direction. Is this clear to everyone? Any problem here? You can ask me, बच्चे. If there's any problem in this question, you can ask me. Similar question was there in your exam few years back. ठीक है. So something like this is how we do a retinoscopy. We prefer a dark room. So generally we use an arm's distance. Sometimes this is 1 meter, sometimes this is 0.575 meter. ठीक है. Arm's distance. Which cycloplegic should we use? In children we use, small children we use atropine ointment. ठीक है. Atropine ointment in small children. Later on we put cyclopentolate as a cycloplegic agent. ठीक है. चलो ऐसा कुछ रिफ्लेक्स दिखता है. सो दैट रिफ्लेक्स इज मूविंग इन द सेम डायरेक्शन और इन द ऑपोजिट डायरेक्शन. मूव अवे मीन्स इन द ऑपोजिट डायरेक्शन. डॉक्टर वेंदन, मूव अवे मीन्स इन द ऑपोजिट डायरेक्शन. चलो easy question. After a catastrophe in some metallic work, a mechanic got injured from a foreign body. So what is the investigation of choice? So you have a clue. There's a metallic foreign body. Probably the patient will have a metallic foreign body. So which investigation should be done? Hanji. What should be the investigation of choice? Anyone? अच्छा, अगर मैं पूछूं विच शुड नॉट बी डन, तो MRI शुड नॉट बी डन. दिस इज एब्सोल्युटली अ कॉन्ट्राइंडिकेशन. ठीक है. इफ यू हैव अ मेटालिक फॉरेन बॉडी, MRI वुड बी एब्सोल्युटली एन आउट ऑप्शन, है ना. So what should be done? CT scan is the investigation of choice here. Okay, you can also go for an X-ray, but if given, CT scan is the best one. ठीक है. Now, जो बच्चे USG-B scan कह रहे हैं, USG-B scan can also be done, but if you have a better option of CT scan, why not? ठीक है. हाँ जी, जो बच्चे USG-B scan कह रहे हैं, have you understood? Somebody said B scan. मेरा आंसर समझ में आ गया बच्चे. USG-B scan can be done, but if you have a better option of CT scan, go for it. What about A scan? A scan का क्या काम होता है? When are we using a A scan of ultrasound? So when we do a biometry for calculation of the IOL power. First of all, for the IOL power, you also can get to know the axial length of the eyeball. So that is the role. Okay? Please remember, this should be a very, very, very important question. हाँ जी, चलो अब आ जाओ. So this question was there in your exam last year. I hope you can answer it easily. All extraocular movements are paralyzed. What is the most probable site of light? Because I want to discuss the question here. That's why I have kept it. The old question, I have kept it for you. Dr. Ecolima, see, I am not explaining anything separate in Hindi. Okay, don't worry. I am telling each and everything in English, so I'm not missing out. You are not missing out anything. If I'm explaining something in Hindi, I'm doing it again and again. Okay? All right, Dr. Ecolima, you are not missing anything. Very good, guys. The correct answer here is midbrain. Okay, midbrain. So all extraocular movements are paralyzed means what? So guys, we have extraocular muscles. We have 6 extraocular muscles which are supplied by I hope you remember LR6 and SO4. So it says that all the extraocular muscles are supplied by third nerve except lateral rectus, which is supplied by the 6th nerve, superior oblique, which is supplied by the 4th nerve. ये हमको पता है. We know this all. So all these nerves are situated at the level of midbrain. Yes or no? So this has to be the answer. So if the lesion is in the midbrain, which is a big one, which has paralyzed all the nerves, the 3rd, the 4th, the 6th, all is gone. So you will have paralysis of all the extraocular muscles. So guys, what do you call this condition to be? We call this condition to be external ophthalmoplegia. External ophthalmoplegia. ठीक है? Please remember, this can be an important question. Okay? Simple था ना ये? Easy question. चलो, ये देखिए. So, a patient came with a history of fight. Again, this is a trauma. He has a non-reacting pupil and a painful loss of vision. So what is the most likely cause? Yes, guys. Dr. Neeraj, some book says that we have 6 extraocular muscles. We don't include LPS because levator palpebrae superioris does not cause attachment at the eyeball. Most of the book says that levator palpebrae superioris should be included because it is an extraocular muscle. It is outside the eyeball. Okay, so this is not a query. Don't worry, it will not be asked. But please remember why we have different answers. This is the reason. Hanji. So if a patient has a history of fight, there is a painful loss of vision and a non-reactive pupil means that means there is something related to optic nerve. Yes. So if you say that there is a trauma and you have a optic nerve avulsion is the rarest of the thing can happen. Optic nerve ut gayi, hat gayi. So this is the rarest thing that can happen. Okay. Now what about the rest of the options? Do we have a painful loss of vision in papilledema? Never. We don't have a painful loss of vision. And what about pupils in papilledema? Pupils are also normal in papilledema. Okay, friends. So this is again the out option. What about rosette cataract? Do we have a painful loss of vision in rosette cataract? No, not at all. And so rosette cataract is also out. So what about optic neuritis? This is the correct answer. This is the correct answer. So optic neuritis patient presents with generally a painful loss of vision, and when you have a painful loss of vision, this is accompanied by which pupillary problem will be there? Which pupillary problem will be there? So it will be a RAPD. What is your question, Dr. Sachin? I haven't understood. Please ask me your question. Please ask me your question, Dr. Sachin. Chalo, anyway, so I'm just quickly telling you what about optic neuritis. Optic neuritis is an inflammation of optic nerve. The most common cause is multiple sclerosis or Devick's disease, where a demyelinating disorder is there, but definitely after trauma you can have optic neuritis as well. Okay, primary optic neuritis can be there in such kind of cases. Okay, बच्चे रोसेट कैटरेक्ट में why will you have a non-reacting pupil and why will you have a painful loss of vision? In rosette cataract, first of all, you develop a very late onset of it takes some time for decreasing the vision. Okay, and why will you have a non-reacting pupil? Tell me. It's a painless thing. Yes, it is a feature of blunt trauma. It is a feature of blunt trauma. But definitely you will not have a painful loss of vision and pupil will not be abnormal. ठीक है? Clear है सबको? Dr. Hema, she is absolutely right. You call it a Marcus gun pupil. Yes, you call it a Marcus gun pupil. ठीक है बच्चे? चलो, good. Now, very easy question. Nerve fiber layer of retina has what? Nerve fiber layer of retina has what? So I hope you remember that retina has got 10 layers. The nerve fiber layer is one of the inner layers of the retina. So what does it have? So axons of ganglion cell is the correct answer. So guys, after ganglion cell layer you have a nerve fiber layer. After the nerve fiber layer you have the inner limiting membrane. So ganglion cell layer has nuclei of ganglion cells, and this nerve fiber layer will have axons of ganglion cell layer, which is further going to form the optic nerve. It is further going to form the optic nerve. Okay? Very good. Now what about bipolar cells and hemacrine cells? These are present in which layer of retina? Anyone? They are present in which layer of retina? Inner nuclear or outer nuclear? They are present in the inner nuclear layer of retina. Okay? Please remember. What about photoreceptor cell body? They are present in the outer nuclear layer of retina. Okay? These questions can be there from retina, friends. Please remember expected questions. So if you go about this section, they can ask you outer nuclear layer has what? Inner nuclear layer has what? Ganglion cell layer has what? Again, outer nuclear layer will have the nuclei of the photoreceptors. Okay? What about inner nuclear layer? It will have bipolar cells, Muller cells, amacrine cells, horizontal cells. Ganglion cell layer will have the nuclei of ganglion cell layer. Okay? Chalo. Ab batao, smile is what? Smile. Smile is what? Here we are talking about the refractive surgeries, guys. Smile is the short form of small incision lenticular extraction. Small incisional lenticular extraction. So ये क्या है? Anyone? So it's a refractive surgery, basically something over LASIK which can correct myopia. It's a more sophisticated surgery, and what is the difference here? I'll quickly tell you the difference in between LASIK and RELEX smile. Okay, सभी लोग देखिए बच्चे. So in LASIK, what are we doing? In LASIK, we are creating a flap. This flap is of epithelium, superficial, Bowman's, and a superficial part of stroma. Very superficial stroma. Okay? What are we going to do? After that, we are placing the laser light. This has the argon fluoride gas. ठीक है? ये argon fluoride क्या करता है? This causes a thinning of the corneal stroma. Yes, it causes a thinning of the corneal stroma. So, depending upon how much correction we want in myopia, we can press the laser button and the argon fluoride gas will come and it will decrease the thickness of the corneal stroma. Okay, this is your LASIK. So, in LASIK, basically we are creating a big flap. Now, what are we doing in SMILE? What is SMILE? Smile is refractive lenticular extraction, or you can say relic smile. They are both the same things. Now, instead of making a big flap, we are not creating a flap. We are making a very small incision, very small. That means a 2 millimeter incision, very small incision. That too with the help of femto laser. ठीक है? ये जो incision है, this incision is not made through the blade. This incision is made through the femto laser. Now, if this is your corneal stroma, we know this much of the stroma has to be taken out. So instead of making a flap, we are creating within the stroma a lenticule. This lenticule has the desired thickness which has to be taken out. And through the small incision on the cornea, we just take it out like this with the help of a forceps. Okay? So what is it? It is to correct myopia, but it is a bladeless and a flapless technique. You need not to put a blade. You need not to make a flap even. Okay? So this prevents the flap related complications. Am I clear, friends? Yes guys, am I clear? Any problem, anyone, please let me know. Okay? So it's a bladeless procedure. It is also a flapless procedure. We are not creating any kind of flap in smile. This can be an expected question, friends. Please remember. Yes, technically more demanding. I would say not really. Not really. Chalo. So, ophthalmic signs in COVID are maximum in how much duration? So, we expected a question on COVID, but it wasn't asked. So, let us quickly discuss something in eye related to COVID. So, ophthalmic signs are maximum within the end of first day or initial period of the second week. Okay? Generally, the patient presents. What is the most common manifestation of COVID in eye? The most common manifestation is acute follicular type of conjunctivitis. Acute follicular type of conjunctivitis. This is the most common presentation. Okay, Dr. HN, Dr. Priya. If you, Dr. Priya, of course, NEET PG students can see it, yaar. If you like it, if you think that the questions are useful to you, definitely it is going to help you. Okay, Dr. Priya, I think I've solved your query. And doctor, somebody asked me about the lasers in smile. I'm going back to this. But listen to me carefully. So, stromal thinning in LASIK is done by argon fluoride laser. Okay? We call it photo ablation. Okay? What about smile here? Smile may we want to make the incision. So, we are using femto laser here. Femto laser. Okay? We call it intralase. Intralase. Okay? Femto lasers are being used. So I'm talking about COVID in eye. So acute follicular conjunctivitis, first of all, it is the most common manifestation of COVID. Almost 4% of the patient presented with this. Okay? Now what is the treatment if you develop a conjunctivitis? Again, because it's a viral, the treatment should be self-limiting. Please. Okay? Don't tell me that you give this drug or this drug. It's not required. This is also self-limiting because it's a viral illness. Okay? Now my next question. Please see. All can be the neuroophthalmic features in COVID-19 except. So guys, you can have anything in viral infections except for a primary optic atrophy. I hope you remember that primary optic atrophy occurs after TTTNH. What is TTTNH? A tumor of the optic nerve, a trauma of the optic nerve, toxin ingestion, nutritional deficiency and hereditary. So primary optic atrophy is never seen after a case of COVID-19. Okay? Please remember an expected question. Okay? Now my next question to you in COVID. Listen to this question carefully. What is the most common cause of loss of vision in COVID-19? Anyone? What is the most common cause of loss of vision in COVID-19? Trauma tutor. Tutor, your tutor is toxic. Can anybody answer? Again, my question, what is the most common cause of loss of vision in COVID-19? So it is not mucormycosis, it is not even optic neuritis. The answer here is vascular occlusions of retina. Vascular occlusions of retina, okay? Like CRVO, CRAO. These are the most common cause of loss of vision in COVID. Okay, if you are given an option of mucor, I'm sure students will mark mucor, but mucormycosis is not. Okay, most common cause of loss of vision is because of retinal problems like vascular occlusions. I hope this is clear. ठीक है बेटा? Chalo, now something very important related to vitamin A. So there's a small child, a 13-month-old baby who had severe malnourishment and weighs 7.5 kgs. Now we are planning to give him vitamin A. Vitamin A, okay? Obviously we will be supplementing the patient with vitamin A. So what dose will you give? What dose? So we have two things. I hope you remember we have two things. If the baby is more than 1 kg of weight and if the baby is more than 8 kgs of weight. So we should be giving 2 lakh international unit orally. But what if the weight is less? The weight is less. What would you give? You will be giving half the dose. So what is the half dose? 1 lakh international unit. Okay? I hope you remember everything here. 2 lakh international unit will be given when you have the birth weight, when you have weight of more than 8 kgs or when you have more than 1 year baby. Okay? If the baby's age is more than 1 year but the baby is underweight, you can't give the full dose. So the dose given will be half. Yes, this is the last exam question and see, students are still confused here. बहुत सारे students confused है, Dr. Neeraj here. So I wanted to tell you again, this is an important topic. Alright. So again I'm telling you, if the baby cannot tolerate the oral dose, if the baby is not able to tolerate the oral dose, then what should be given? You can give half the dose, that is 1 lakh international unit intramuscularly. This is one and the same. Baby is having a lot of kwashiorkor, malnourishment, he is not able to tolerate the oral dose, then you can give 1 lakh international unit intramuscularly as well. What about the small babies less than 1 year or less than 8 kgs? You have to give half the dose, that means 1 lakh international unit oral or half the dose of this as intramuscular dose. So that means 50,000 international unit intramuscularly. Now is the concept clear? Everyone, अब तो गलत नहीं करोगे इसको? I hope you won't make a mistake now, friends. It is important. Now again, if I show you this picture, I ask you the same question. The baby has developed a bite or spot. So how will you treat? The same. The same. Okay? So what is bite or spot? Bite or spot is a triangular foamy patch where this is the first sign of xerophthalmia. This is not the first sign but a sign which is very specific. Okay? I'm not saying this is the first sign. It is very specific sign though, but not an early sign. The earliest sign is conjunctival xerosis. This is the earliest sign. And I'm sure you know what is the earliest symptom. The earliest symptom is night blindness. So this table is also very important. ठीक है बच्चे? Bite or spot, the picture question is also important. Okay? Chalo. Now let's see this picture. Again a picture question. Don't make a mistake and don't say this is the bite or spot. This is a picture of pterygium, which is a fleshy mass encroaching on the cornea. Okay, so this is something very different. If I ask you what is the treatment of choice for pterygium, anyone? What is the treatment of choice here? The treatment of choice is excision of pterygium with a autografting. Nowadays they can ask you a question on perfect surgery as well. Perfect surgery is done for which pathology? So it is done for pterygium. Okay? Perfect surgeries. Okay? Chalo, let us see this question. So there is a patient who presented to you with a lot of headache since 2 days. The anterior segment findings are normal. Intraocular pressure is also normal, 20 and 18. In retina, you notice a disc edema. What is the most important finding that differentiates papillitis from papilledema? Hanji, anyone? So read this question well. I'm asking you, probably the patient has a papilledema, है ना? There's a headache, but rest everything is normal. But when you see retina, what do you see in retina? Edema of the disc. So can it be papillitis? Tell me, can it be papillitis? Absolutely not. Papillitis तो नहीं होगा. क्यों? Because in cases of papillitis, your vision will be less, है ना? And we have not mentioned about vision. So this is definitely a case of papilledema. Now if I am dealing with papilledema and I am still confused in papillitis and papilledema, what is the first important thing which will differentiate this from this? Hanji, anyone? Can you distinguish papillitis from papilledema in any other aspect? I have told you the first difference. Vision is decreased in papillitis, vision is normal in papilledema. Any other thing? The most important rather. So I've given you a clue as well. This is the correct answer. What about pupils in papilledema? Hanji, what about pupils in papilledema? So pupils are normal in papilledema, yes or no? What about papillitis? We have just discussed. In optic neuritis, the pupils are abnormal. Yes or no? Now, if I talk about these three, definitely all of these three are also helping you in distinguishing papillitis from papilledema, because the degree of disc edema can be very large in papilledema. You may have a lot of venous toxicity, you may have a hemorrhage on the disc as well. But please remember, in early stages, papilledema and papillitis are not distinguished easily in early stages. Okay, so it is definitely always and always the pupil and vision which will tell you the diagnosis. Hanji, understand? Dr. Vicky, you are very right. Papillitis is almost always unilateral, almost always, and papilledema is almost always bilateral. Very good, very good. But again, I'm saying, because it's a history, a short duration history, so you can have a very subtle change in one eye in papilledema as well. Okay, but yes, absolutely right. Okay, guys, are you able to understand? Pupils and vision is the one which differentiates papillitis from papilledema. In papillitis, the patient presents with a loss of vision, pupils are abnormal. In papilledema, patient presents with headache, vomiting, nausea, pupils are normal. Okay, chalo. So what appearance is this? You also call it angry sun appearance, है ना? इसको angry sun appearance भी कहते हैं ना? You remember? Because the disc edema is huge, you can't make out the margins of the disc, there are a lot of hemorrhages, veins have become tortuous, you have exudates as well. So what will be the finding in cases of perimetry? You will have an enlarged blind spot. This is the condition where you can see enlarged blind spot. Why enlarged blind spot? Why enlarged blind spot? Because your disc is enlarged, so your blind spot which corresponds to the disc will also be enlarged. ठीक है, ये पूछते हैं question, you can have a picture question as well. All right, chalo, a very simple one, common sense. Let us see if we have common sense, if our common sense is so common or not. Okay, what about this, ma'am? Vikrant, Hanji, pterygium will cause obscuration of visual axis. Yes, if it is large enough, it will come on the visual axis and it will cause a lot of decrease in vision. But more than that, pterygium will have a decrease in vision because of causing a with the rule type of astigmatism. ठीक है? Okay? Vikrant, ऐसे होता है बच्चे. It causes obscuration of visual axis when your pterygium is large enough to cause such a problem. All right? Chalo, a patient is prescribed ointment and 2 drops by a doctor. What is not true about these dosages? So, what is not true? Think about it and answer. What is not true? Very good, Dr. Patel. Yes, we never apply the ointment first. If we are given 2 drops and 1 ointment, we prefer that 2 drops should be given at an interval of 10 minutes. This is a correct statement. every time you prescribe the drop, you must tell the patient that one drop is sufficient. What is our habit? We keep on putting the drops, है ना, एक नहीं, दो नहीं, तीन डाल लेते हैं, चलो जल्दी ठीक हो जाएंगे, but ऐसा नहीं होता. One drop is sufficient every time, okay? And if we are giving an ointment, we prefer it for the night time, and if at all the doctor has prescribed ointment twice a day, ointment should be put in the last. Why? Because it is sticky. If you put drops over the ointment, the drops will not penetrate, okay? I hope this is clear to all of you. Now I would tell you something again, very important. Please remember why I am saying one drop is more than sufficient. The reason behind this is the sac, the conjunctival sac within which you place the drop, it is having a very little capacity, 30 microliter. And what is the size of a drop? Generally it is 50 micron. So this is more than the capacity of the fornix. Okay, this is important. Chalo, now again an expected question. Can you identify which type of lens is this? Is it a unifocal, PCIOL, normal posterior chamber intraocular lens? Is it a multifocal one, accommodating, or a toric lens? So can you identify what type of lens? What is the clue here, bache? What is the clue here? So this is the clue. The line is the clue. What is that? Which lens is this? The correct answer, it is a toric lens. ठीक है, expected question this year. Now toric lens में क्या होता है बच्चे, सभी लोग देखिए. So toric lens is a kind of lens which is used to correct a pre-existing astigmatism when we are doing a cataract surgery. Suppose कीजिए एक patient है, there's an old patient who has a lot of cataract and he also has a lot of astigmatism. So when we are implanting a lens during the cataract surgery, we make sure that if possible, we can implant such type of toric lens. So can you see the markings? If we put the lens in such a way that the marking is there on the steeper axis. Steeper matlab, suppose ये cornea है and after biometry we come to know that certain axis is the steeper axis. Certain axis is more curved. And because of this more curve, you have an astigmatism. So when you are putting the intraocular lens, you align the lens in such a fashion, you will rotate the lens in such a fashion that the markings are coming on the same area where the cornea is more steep. So it will correct the pre-existing astigmatism. So it is basically to refine the surgical outcome. ठीक है, आपने सर्जरी करना है, you want to give best of the vision to the patient. So if he is having an astigmatism, he'll have to wear glasses. For that, patient will not be happy. So why not to give him a best possible correction in the form of these lenses? Am I clear, friends? Expected question. ठीक है, multifocal कैसा होगा? How will be the multifocal lens? Somebody has answered multifocal. Multifocal means what? It will have few zones, different zones. So this will let you see for the near vision, this is for the far, this is for the intermediate vision. Okay, multifocal, it will correct for multiple distances. Okay, this will be the shape of a multifocal lens. Am I clear? What will be the shape of multifocal lens? Clear? ये पूछ सकते हैं. हाँ जी. Now, correct sequence of progression of the visual field defects in glaucoma. Guys, this is your question. Try to answer this. हाँ जी. So, what is the correct sequence of progression? हाँ जी. So, first of all, what appears? First of all, we have a little constriction of the visual field. What happens next? We have bearing of blind spot, then we get a sedal scotoma, then we get a ring scotoma, and finally in the last stage, why you have a temporal island. Dr. Neeraj, ये PCIOL तो है ना? It is a PCIOL because we have line here, we call it a toric lens. Okay, a normal PCIOL will be like this, but it will not have these markings. If you have these markings, that means I'm talking about toric lens. ठीक है Dr. Neeraj? Okay बच्चे? चलो अब मैं quickly I'm making a diagram so that you can easily quickly revise the visual field changes. Just listen to me what I'm drawing. So this is the normal visual field where we have the blind spot. Okay, this is the normal visual field. Now as the first change in primary open angle glaucoma, isoptric contraction, your visual field will be slightly smaller, slightly. Okay. Next is bearing of the blind spot. This area is now gone. Whatever you have, your patient has is this area now. Okay. Now the next is Presence of a paracentral wing shaped scotoma. So the patient will develop this kind of scotoma. Gradually, this will join with your blind spot to become a sickle shaped scotoma. We call it a sedal scotoma. So this is what is sedal scotoma. It enlarges to the horizontal side. It becomes an arc shaped scotoma. We call it arcuate scotoma. Gradually, it will become a double arcuate scotoma. We also call it a tunnel vision or a donut shaped scotoma. What is left? Your central vision is left, and finally in some cases central vision is also gone. What you get is a small temporal small temporal island of vision. Okay, this is how your visual field progresses. Okay, all right, chalo. Now, important expected question. Okay, something related to a refractive error. See and read the question. Very, very, very practical, what you see in day-to-day life. A 10-year-old boy came with difficulty in copying from blackboard on school. That's what we have patients in our OPD. His mother also complains that he sees television from very close. बहुत पास जाके TV देखता है ना. Also he squeezes his eye like very often, like this, squeeze the eye. Now when he visited you, the vision was found to be less, 6/36. So what is the most common cause of such a problem? What is your first differential diagnosis? Hanji, answer. Answer in the chat box. What is your first differential diagnosis? Anyone? So my first differential diagnosis is my patient has a myopia. Okay? Now we know that myopia is a nearsightedness. The patient has a problem in looking at the television and the school board. So he has problems from copying from blackboard on school. What he does is squeeze the eye. When he squeeze the eye, we call it shut eye. Shut eye. Okay? ऐसे करके देखता है, shut eye. Now, I have told you many times in myopia, what is the most common cause? Most common cause is a big eye. Big eye myopia, small eye hypermetropia. So increase in the length of the eyeball is the most common cause of myopia. We call it axial type of myopia. Okay? Increase in the size of lens, increase in curvature of the cornea, they are also responsible but not equally responsible. The most common type, the most common cause of myopia is increase in the length of the eyeball. Am I clear? Increase in the... Yes, Dr. Ayush is absolutely right. Slit effect. He is creating a slit effect or a pinhole effect. Very good, Dr. Ayush. By squeezing the eye, the children make a slit effect. So that improves the vision for distance. Okay? It's a very common complaint, guys, what we have in the day-to-day OPD. Okay? Everyone, is it clear? Important expected question because it's a practical problem. That's how you see children with myopia. Shut eye. Okay, they create a pinhole effect or a slit effect. All right, chalo. So quickly revising, what are the different features of myopia? You can have different degenerations like lattice degeneration, snowflake degeneration. You can have hemorrhage, foster fugue spots in myopia. What type of retinal detachments can we have in myopia? We can have a rhegmatogenous retinal detachments. We can develop a lacquer crack, that is break in the Brooks membrane. Crescents can be seen. Posterior staphyloma is a very, very important question because we have large eye. Disc will be large, cup to disc ratio will also be large. That is why they are a differential diagnosis of open angle glaucoma. Yes or no? What do we have in primary open angle glaucoma? Large cup to disc ratio. Myopes also have a large cup to disc ratio. So they become a differential diagnosis for POAG. See, Dr. Sheena, if the question says all of the above, definitely all of the above is the answer. But the question option number 4 says all of the above is equally responsible. I am saying they are responsible but not equally. ठीक है बेटा? Read the language of the question. Read the language of the question. ठीक है? चलो. So this is your foster fugue spot, that is hemorrhage in the macula. Right? You can have lacquer cracks, that is breaks in the Brooks membrane. Now again a repeat question. Diagnose the condition. So guys, similar questions can be there again in your exam. So this is typically a case of third nerve palsy. If you see such type of picture questions, what is the first thing that we have to see is the central one, the primary gaze. Primary gaze, okay? In the primary gaze, what can we see? There is a ptosis in the left eye. Yes? The eye is also down and the eye is also out in all the gazes. The eye is down and out. So which movements are not seen? I hope you remember in the third nerve palsy, we have the eye which is down and out. That is the mnemonic which I always tell the students. Down and out eyes for third nerve. So which movements are not possible? Elevation is not possible because both the elevators are paralyzed. है ना? Superior rectus, inferior oblique both are paralyzed. So elevation is out. Which is also not possible is the adduction of the left eye is also not possible. These are not possible. Okay? Important question. चलो ये बताइए a very simple one. What is not a differential diagnosis of this condition? So a patient has come to you with a red eye. There's a little haze in the cornea, very little haze in the cornea, and what you see is this. क्या है ये? What is this? We call it hypopyon. So what is not a differential diagnosis? Guys, answer. Important expected question. Yes, Dr. Veera. Yes, it is dose is out and down eye. I've just gone a step ahead. I am asking you in this patient which movements are not possible. Okay, which movements are not possible? Elevation and adduction of the left eye is not possible. ठीक है? चलो इधर आइए फिर से. What is not a differential diagnosis, beta? Is conjunctivitis a differential diagnosis? Can you have a hypopyon in conjunctivitis? See, this is such a simple question, but again you have marked the wrong answer. Can you have hypopyon in cases of conjunctivitis? Now, if I am asking you about corneal ulcers, there are some ulcers which cannot be picked on naked eye, like viral ulcers. You can't pick them on naked eye. Yes? So, conjunctivitis is the answer here. Now, my simple, very simple question. What are the differential diagnoses of acute painful red eye? Hanji, quick. Acute painful red eye. Very simple. Patient presenting with PVR symptoms, pain, loss of vision and red eye. What are the causes? Corneal ulcer is one. Uveitis is one. Angle closure glaucoma is one. Endophthalmitis is one. And scleritis. So there are only 5 conditions in ophthalmology where the patient will have a acute painful red eye with a loss of vision. Okay? ठीक है? Clear hai friends? Okay, so there are only 5 conditions in ophthalmology where the patient can have this type of picture. In conjunctivitis, you will never have a hypopyon. Okay friends, please remember. Chalo, ye dekho something again very important expected one. So a young man of 30 years had a history of redness in eyes since many months for he which took topical steroids. Again, suppose there was a small ulcer which is barely visible through the naked eye. Patient just have a acute painful red eye, but the ulcer was not visible. And he has been taking what? He has been putting steroids. Now he developed similar complaints again. And slit lamp is now showing you this picture. Ye kya hai? What is this? Very important topic. I'm happy that you've answered right. This is a case of geographical ulcer. Very nice. So what was the sequence of events that has been followed? So I hope you remember recurrent corneal ulcers. If we are talking about, then it must be viral ulcers. Okay? Recurrent ulcers are generally viral ulcers. The moment your immunity goes down, the moment you develop a slight fever, you have stress, lot of sunlight exposure, these are some risk factors that your virals can become triggered. Okay? And if because of that there's a little redness, little pain in the eye, and you have been taking topical steroids, then what can happen? All these dendrites, जो dendrites थे, these all dendrites will join together and they'll make a big ulcer, and this big ulcer is called as a geographical ulcer. Very nice. Okay, it looks like a word map. Yes, that's why we call it a geographic. It includes a big geographical area. Okay, now my next question. So which dye I have used? Which dye is this? This dye is your fluorescein dye, isn't it? This dye is fluorescein dye. So what is the role of fluorescein dye? It will stain any epithelial defect green in color. So ये green kya hai? This green is the epithelial defect or the ulcer. Okay. Now please remember, steroids are absolutely a contraindication in viral ulcers. Yes, as Dr. Nitesh has told us. Very good. It's absolutely a contraindication. Okay? Now this was the picture of dendritic ulcer I was mentioning. So suppose this is the ulcer. This is barely visible to the naked eye. ओके ज़रूरी नहीं है ये मुझे नेकेड आई से दिखाई दे. आई नीड अ स्लिट लैम्प, आई नीड अ फ्लोरेसेंट डाई टू डायग्नोज इट. नाउ if I am a quack, or if the patient just goes to a chemist shop, the chemist will be giving him steroids because the patient has a little inflammation, little red eye. So what will happen? These dendrites will join together and it becomes a geographical ulcer. Okay, please remember. Now what about true dendrite? How is it true dendrite? True dendrite will have knob at the end. Okay, true dendrite will have a knob at the end. Please remember. Okay, true dendrite. So they can ask you again this question, true dendrite. Okay, now what about herpes zoster ophthalmicus? My next question is, which rule is being followed? Hanji, which rule? So this is Hutchinson's rule. What rule is being followed? We have Hutchinson's rule here. Hutchinson's rules predict the ocular involvement. If I have a vesicle at the tip of the nose, if the vesicle at the tip of the nose is present, the eye involvement will also be there. This is called as Hutchinson's rule. Okay? Which nerve is involved here? We have involvement of nasociliary nerve. Nasociliary nerve. Okay? Chalo, good. Now, again coming from ROP, a baby was born in 29 weeks of gestation. He also developed a respiratory distress. Okay? This is the two risk factors are there. The baby has a low gestational birth age. He also has a respiratory distress. Okay? And on 5th day of life, he had developed sepsis also. So when you want to screen for retinopathy of prematurity, if you want to screen for retinopathy of prematurity, I am asking you, when would you screen? When would you like to screen? So the rule is, you will screen this baby after 4 weeks of birth, not today, not even within 2 to 3 weeks of birth. So this is when the doctor should screen. So I hope you remember, less than 34 weeks. If the baby is very small, that means he's been born in less than 28 week of gestation. बच्चा बहुत छोटा है, the child is very very small. You screen early. You screen early means within 2 to 3 weeks of birth. But if the baby is little big, more than 28 weeks but less than 34 weeks, then you can wait. You can wait for 1 month. Okay, have you understood this question, friends? So we have two different screening criteria depending upon the age of the baby. We say if the baby has to be screened after birth, if the baby is very very small, less than 28 weeks, you should screen him early, within 2 to 3 weeks of birth. But if the baby is little big, that means he is more than 28 weeks but less than 34 weeks, somewhat around 29, 30, 31, even 32. So you can wait till the normal vessels develop. So it is after 1 month of the birth. Okay, am I clear? So these 2-3 questions from retinopathy of prematurity is important. Okay, chalo, ye question something from your NEET PG friends which were asked in their exam. Expected question this year from you as well. Extra eyelash behind a grey line is what? This is some eyelash abnormality, guys. What do you call it? We call this condition to be dystichiasis. Okay, so I'm just showing you a picture because this is an important picture question. Dr. Hema, screening includes mainly the retinal examination. We want to screen the retina because we want to check up which area of the retina is avascular, what is the extent of retinopathy of prematurity, has the normal vasculature developed or not. Okay, screening here means the retina checkup by an ophthalmologist, by a retina specialist. Okay, Dr. Hema? ठीक है बेटा? Chalo. So guys, picture questions are also important. So what do you understand by trichiasis? Trichiasis means misdirected eyelash. Normally eyelashes are like this. This is your trichiasis. What is dystichiasis? Dystichiasis is this extra row of eyelash. I hope you know that if we talk about the lid margin, अगर मैं सिर्फ ये margin का बात करूँ, lid margin is not a single line. No, it is having a particular width around 2 millimeters. And this has two zones, the anterior zone and the posterior zone. From the anterior zone we have eyelash which comes out, And from the posterior part of the lid margin, we have meibomian gland opening. You know the meibomian glands? The opening of the meibomian gland is present in the posterior part of this gray line. ठीक है? Dr. Neeraj, this is not trichiasis beta. आप समझ में आ गया? Dr. Neeraj, have you understood what is trichiasis? Trichiasis is misdirected eyelash. Misdirected. Okay, pseudotrichiasis is seen in case of entropion. What is entropion? Inward turning of the lid. Lid पूरा turn हो गया अंदर. So it is like pseudotrichiasis. Madarosis is absence of eyelash or eyebrow. ठीक है? Dr. Neeraj, okay? Dr. HN, is it okay now? Don't get confused. The very, very important terms, very important topic as well. You can have picture questions also from this. Dystichiasis, extra row of eyelash. Chalo. Coming from the next one, something related to a problem of an old man. He is 50-year-old and now he has problems in reading newspapers. पहले मुझे बता दो इसका क्या diagnosis है? What is the diagnosis? A 50-year-old man came with difficulty in reading newspapers. What is the diagnosis? Quick. The diagnosis here is presbyopia. Now, is presbyopia a refractive error? No, it is not a refractive error. है ना? It is a age-related physiological insufficiency of ciliary muscles because ciliary muscles is now weakened and we cannot focus for near objects. Okay, so for reading the newspaper or for reading my mobile, I would need a plus power of glass. So for 50 years, what I would like to give? Yes, madarosis में बच्चे बहुत सारे causes होते हैं. Madarosis can be seen when you have a trichotillomania, psychiatric disorder, after chemotherapy, blepharitis, hypothyroidism, leprosy you can have, Hansen's disease में हो सकता है. ठीक है? So that's a old age related condition. Now answer to this question is 50 years में हम देते हैं +2 diopters. Okay, please remember from 40 to 45 we generally give this, from 40 to 49 we give this, after 50 years we generally give +2. ठीक है? Generally we give, but definitely we just can't give like that. We have to see the acceptance of the patient. Okay, so this is the correct answer. In 50 years of age we generally give 2. Yes, this is a convex glass. This is a convex one. Okay, chalo ये देखिए. So a difference between the visual acuity of two eyes seen in a patient. Left eye has a vision of 6/18 and right eye has a vision of 6/24, which is not improved further. So what can be the most common cause? So guys, please read this statement, which is not improved further. Which is not improved further means, what is the diagnosis? If you are not able to improve the vision from these, what is the diagnosis? So the diagnosis will be amblyopia. So what is the definition of amblyopia? You call it a lazy eye. There is a poor visual acuity less than 6/12. Less than 6/12, which is not improved further. है ना? So a patient has come to you. There's a difference in the vision. Okay? And the vision is because the patient probably has a refractive error, which is not being treated well in time. Now the patient has developed an amblyopia. Now the patient has developed a lazy eye. Okay, so cataract is not the answer, beta. No, cataract is not the answer. Mostly it is anisometropic amblyopia. So what is the meaning of the term anisometropic here? Yes, anyone, what is the meaning of the term anisometropic? Anisometropic means difference in the refractive status of two eye. Difference in the refractive status of two eye. मतलब क्या हुआ इसका? It means the patient either has a -1, -2, -3, -4, something like that. Difference in the refractive status of two eye. And probably the patient has a lot of refractive error, and that is why the patient was not being corrected in time, and that's how he developed a amblyopia. So is my question clear to you? See, Dr. Hema, an isometropic amblyopia I would say is a better answer. Suppose if C option is not given, suppose, then the answer would have been B. ठीक है? Dr. Hema, if option C is not given, the answer would be B. But if the option is given of anisometropic amblyopia, that should be the best answer. Okay, I hope you have understood unequal refractive errors. Dr. Dream, is this also clear to you? Yes, so occlusion can be done in a patient till 8 or maybe 10 years of age. Afterwards, the role of occlusion is gone. Okay? All right? So this can be an important expected question. बच्चा please इसको पढ़ लेना. चलो ये बताइए. So similar question was there in your exam last year. So a patient came with history of allergy with a contact lens and he also has a foreign body sensation. What is the most common diagnosis? GPC, VKC, corneal aberration, acanthamoeba ulcer. So what should be the best answer? Anyone? Now, if I have not mentioned the term contact lenses and I have mentioned about a young boy, maybe in his first decade, then the answer would have been VKC. But I have mentioned specifically about the contact lens, so GPC has to be the correct answer. Okay, VKC will have a different type of history. Both of them are allergic. Please remember guys, there's a lot of confusion between GPC and VKC to many students. Please understand this. Okay, this is important for our NEET PG students as well. Please see, both of them are hypersensitivity reactions, definitely. But in giant papillary conjunctivitis, what do you have? You develop large papillae on your upper palpebral conjunctiva. The appearance of papillae is very similar to cobblestone papillae, apart from that there is an empty area. You can see a little bit of empty area in giant papilla. Now giant papilla, earlier we used to say that more than 1 millimeter is giant papillae, but nowadays we say even a papillae more than 0.3 millimeter should be included in the definition of giant papillae. Okay? The first difference. Okay, you can have clear areas, but if given a picture of a cobblestone papillae, many a times you are not able to distinguish between these two. So in that scenario, you should talk about the history of the patient. You see the question, if you have a history of contact lenses or a history of presence of suture in a patient's eye, suture which is eroded, suppose there is a suture here which keeps on eroding the patient's conjunctiva, then any kind of mechanical irritation, suppose there is a prosthesis or suppose there is a silicone band that we have tied in cases of retinal surgeries, so some kind of prosthetic material, a foreign body there in the eye which can cause a mechanical irritation in the conjunctiva can give rise to a giant papillary conjunctivitis. But if you just talk about picture related difference, it's difficult for us even to answer. Okay, Hanji, now your questions, you are asking me why not acanthamoeba. अच्छा बेटा, see acanthamoeba में क्या सिर्फ foreign body sensation होएगी? Acanthamoeba ulcer is the rarest of the rarest thing will to be happening, and acanthamoeba ulcer is just because you are saying contact lenses. So mind you, even in contact lens users, pseudomonal ulcers are most common. Please remember first thing. And if you have a patient of an ulcer, will it only give you a foreign body sensation? Guys, the patient will present with PVR symptoms, pain, decrease in vision and a red eye. Okay? Dr. Nitish, Dr. Shreya, समझ आ रहा है? Are you able to understand? Why not acanthamoeba ulcer is the answer here? Because we have better answers. There is a history of allergy. So acanthamoeba ulcers, do we have a history of allergy with contact lenses? No. Acanthamoeba ulcers are seen mainly in contact lens users, definitely. But please remember, these ulcers are the rarest of the rare ulcer and the presentation would be entirely different. I hope you know the acanthamoeba ulcers are the most painful ulcers. You remember? Okay? Rest of the things are not mentioned. Yes, Dr. Sheena, absolutely. It's unbearable pain. Chale aage. So let us talk about the next one. Yes. Expected question. So पहले तो क्या है ये spot diagnosis? What is this condition? Spot diagnosis. What is this? A lid problem. It is a lid problem. So what is it, friends? This is a picture of lag of thalamus, है ना? This is a picture of lag of thalamus. What is happening? The patient is unable to close the eye. Okay? This has happened because probably there's a facial nerve palsy. There's a seventh nerve palsy. Why there's a seventh nerve palsy? Maybe anything. Dr. Jeff, this is not ptosis. That's not ptosis. This is the picture of ptosis. Whenever you are in doubt, see the normal eye. Here the eye is open. The patient is not able to open the eye. Patient is not able to completely open the lid. And what do we have here? See the normal eye. The patient's eye is closed here. So whenever you are in doubt, please see the normal eye. So if you have lag of thalamus, what is the problem? Inability to close the eye completely. So if the patient is not able to close the eye completely, what can develop? The cornea will get exposed. And what you get is exposure keratitis. Am I clear? Hanji, Dr. Fly on the Sky is right. There is a paralysis of orbicularis oculi. Look at me, friends. We have a facial nerve. It supplies orbicularis oculi muscle, which is a circular muscle around the lid. Orbicularis oculi helps in closure of the eyelid. If you have a fifth, seventh nerve palsy, exposure keratitis will develop, and we call this condition to be a neuroparalytic ulcer. Okay? This is a type of corneal ulcer which develops because of exposure to the cornea. Okay? Very good. Most of you are right here. So, see this question. Now we are talking about ptosis. Yes. Ptosis. Hanji. So, bilateral ptosis is seen in all except myasthenia, Kearns-Sayre syndrome, myotonic dystrophy. Common sense. Common sense wala question hai ye. This is a question where you can answer it with the help of your common sense. So ptosis bilateral is not seen in. I hope you know that ptosis is because of mainly the problems of levator palpebrae superioris or the problems in third nerve, because the third nerve is the one which supplies the levator palpebrae superioris. So all the conditions where you have a muscular problem like myasthenia, Kearns, muscular dystrophies are these, hai na? So in Marfan syndrome, you will not have a bilateral. Why are you answering B, all of you? Nahi bache, myasthenia, rather you can have a bilateral ptosis. This is the most common feature rather. है ना? What do you have in myasthenia? Ocular feature क्या है myasthenia का? What is the ocular feature? Bilateral ptosis. Okay, so see, this is a right congenital ptosis. Please identify this is how ptosis develops, and this is one condition where you have a bilateral ptosis. This is not myasthenia, this is something else, but I just want to show you that myasthenia can have a bilateral ptosis. Amitabh Bachchan, yaad karo yaar. Amitabh Bachchan's ocular myasthenia, bilateral ptosis, okay? Never forget this. Chalo, something about staphyloma. So guys, I hope you remember staphyloma was there in your question last year. Now I am not talking about anterior staphyloma, I am talking about ciliary staphyloma. So ciliary staphyloma is what? First of all, you have an ectasia. Please see everyone. You have an ectasia of the outer coat of the eye where your protrusion is in the ciliary body region. Okay, that's how your anterior staphyloma looks like. Protrusion of the corneal region with the underlying uveal tissue as the iris. Now, this is a picture of ciliary staphyloma where the bulge of the sclera is there and the underlying uveal tissue is in the ciliary body region. ठीक है? अब question क्या है जरा देखें. So this is the question. Ciliary staphyloma can be seen in all except. Now I want you to answer. Very simple question, again common sense. I have shown all the pictures to you. Now you have to answer me where you will not get a ciliary staphyloma. So where you won't get a ciliary staphyloma? I am waiting for your answers. Yes, friends. None of you. So, see देखो बच्चे कितना important question है ये. What you have done, let me tell you. So last year your question was on anterior staphyloma. So at least you should be through with anterior staphyloma, yes or no? So if you know about anterior staphyloma, you must have read the most common cause of anterior staphyloma is a perforation of the corneal ulcer. If there is a perforation of the corneal ulcer, then only you will develop an anterior staphyloma, yes or no? So will it cause a ciliary staphyloma? No. Understood? So this is the answer. Perforation of the corneal ulcer will cause a anterior staphyloma, not a ciliary staphyloma. ठीक है बच्चे? Mixed answers है ना? Perforated corneal ulcer will cause an anterior staphyloma. Yes, absolutely, Dr. HN. Absolutely right. Very, very good. Okay. So some types. Now, the last question for this session is about ophthalmoscope. That's a very, very important instrument. So, ophthalmoscope holding in right hand to the left eye of the patient. Blurred nasal margin is normal. Most useful in diagnosis of retinitis pigmentosa. Distant direct ophthalmoscope identifies a subluxated lens. So, you have to tell me about the true statement, the correct statement. Anyone? What is the correct statement here? So friends, if I talk about direct ophthalmoscope, this is my direct ophthalmoscope which I hold in my right eye to see the right eye of my patient. Okay? So holding in right eye for the left eye, no. Right eye, right hand, my right eye. Blurred nasal margin is normal? Absolutely not. If you see blurred nasal margin, probably you can have a papilledema in the patient. So this is absolutely not normal. Is it most useful to diagnose retinitis pigmentosa? No, friends. You want to see the patient with indirect ophthalmoscope, or you want to do a ERG to diagnose a retinitis pigmentosa. Yes or no? Now, what about this distant direct ophthalmoscopy? So, distant direct ophthalmoscopy is this. Please see, this can be a picture question for you. You use an ophthalmoscope but at a distance of approximately 33 centimeters. Okay. Or generally we use a distance of 25 centimeters. Okay? 25 centimeters, and once you see the reflex in the patient's eye, if you see the edge of the lens in the pupillary area, if edge of the lens is seen, that means there is a subluxation of the lens. Okay? Is that clear, friends? Is this clear, friends? So subluxated lens can be seen if you see the edge of the lens in the pupillary area. Normally you don't see the edge of the lens. Okay? So this is how your distant direct ophthalmoscopy works. Okay? Now, this is the picture of indirect ophthalmoscope where we use a 20 diopter lens. Kitni power hai iski? We have the power of a 20 diopter here. Okay, so that has been done from a distance of approximately 1 arm. 1 arm ka distance pe aata hai. ठीक है? Now, at 1 arm distance, you do a indirect ophthalmoscopy. And what is the advantage of indirect ophthalmoscopy? The advantage is that you can see almost all the retina. You can see almost peripheral retina also. You can see a 3-dimensional image. We can also have a magnification which is up to 3 times in indirect ophthalmoscope. Okay. So this is about your ophthalmoscope, and we are almost done with the session, guys. So I hope you have learned something and you are able to revise most of the questions in ophthalmology. So do let me know. So friends, I hope the session was useful for you, and in these 2 hours we are able to revise most of the questions in ophthalmology. I've shown you few images and few expected questions we have discussed. So kaisa lag raha hai? Did you get some confidence after this class? Yes, it will be there for you till your exam, till your FMGE exam. So guys, we are with you. Whatever problem you have in ophthalmology, you can tag me at the DocTutorials group there at Telegram. Okay, so you can join with the DocTutorials group at Telegram. Okay, and you can tag me as the faculty for ophthalmology for any doubt related to your preparation. Okay, so we can be connected again, guys. If the problem is there in I got so much wrong. It's okay, bache. Dr. Neeraj, it's absolutely okay. So let's end this session, and best of luck from everybody at DocTutorials and embryology. But embryology may I'm not expecting any question apart from the congenital abnormalities. No other question. I'm not expecting any question from embryology. Right? But yes, something I'm expecting from the surgical procedures.